Welcome back, Synapse Care family. We are here for another live stream with Kim Marsh and Heather Young from Omaha Children's in Nebraska. In this presentation, Kim and Heather outline the process that they went through as they improved skin to skin in their level 4 nursery. This was a project that was inspired by them coming to a One conference in 2018. And at the One conference, we encourage our attendees to not only learn, but to be inspired to go back to their nursery and to do something. So Kim and Heather came together as a pair to this meeting, and they were inspired to change skin to skin care in their nursery. They started out with reviewing their current policies and their data, which you're going to hear about in this presentation, and then they implemented change. You are going to really enjoy to hear not only just their practical tips of how they improved skin to skin care, but also changed the culture in their NICU. I really hope that you stay all the way to the end so that you can hear some of their questions. And don't forget that you can get the slides and other resources related to this by clicking in the show notes, the link, or the QR code on this page. Don't let me forget to also introduce Lauren Heimel, who was part of our planning committee for the One Conference 2021, and she was doing the introduction. So thank you, Lauren, for that as well. Again, thank you for being with us for our Monday live streams, and I hope you enjoy this presentation with Kim Marsh and Heather Young.
All right, everybody, we are going to continue on. And next up, we have Kim Marsh and Heather Young, and they're going to tell us a little bit about a quality improvement project they did in their unit to increase skin to skin in their level 4 NICU. Kim has been a neonatal nurse practitioner for the last 14 years at Children's Hospital in Omaha, Nebraska. Her passion is babies with neurological issues and developmental care, and she's the co-coordinator of the NeuroNICU at Children's with Heather Young and Dr. Peeples. And Heather Young has been a practicing pediatric occupational therapist at Children's Hospital and Medical Center in Omaha since 1998. And since 2016, she has been their NICU's developmental care specialist. So let's welcome Kim and Heather.
Hi, guys. Everyone. Good morning, everybody. First, we just wanted to start and thank Kathy and the team for inviting us to talk at the conference. Our talk is going to be an example of what you can do once you leave the One conference, because Heather and I attended the conference in San Diego in 2018 and then came back and tackled the skin to skin. But we freaked out a little bit when we saw who we were following this morning, because we have so much respect for Mary and what a fantastic speaker she is. But then Heather and I were sitting here talking this morning then too. It's our story about what happened after we left the One conference. So it does do a fairly good job, and we don't know if it was on purpose or if it just worked out that way, but it does help us feel a little bit better about following Mary. Just to explain real quick, the one member who's on the first slide that actually isn't going to talk this morning is Dr. Peeples. And Kathy was excited because she thought maybe Eric would be with us. We didn't even offer him the opportunity to talk. We just decided to do it without him, although he likes to not be in the limelight or do any talking, even though he's an amazing speaker. But he is on here because he's the neo who pushed us, who helped us with the paper and really helped us with this initiative. We also are not internationally known, nationally known, even locally known speakers. So we didn't make an objective slide. We're like you guys. We're the people who attended the conference. We're the people who learned about the things. So we didn't make an objective slide, but we're like, we should probably mention what the objectives are, just so that you guys can, when you see them, you'll recognize them. Our main goal was to tell you 3 multidisciplinary team members that were involved with us, to identify at least 2 barriers to increasing skin to skin, and then some interventions, that at least 2 interventions that we did to help increase the skin in our unit. The lovely picture that you see up now is a picture that Heather and I took actually before the San Diego conference started in 2018. We decided to do all kinds of sightseeing, which we're all missing on these Zoom/WebEx, everything that you're doing. But we went to the national park there, which neither of us could remember the name, but we did go to Torrey State Park to go hiking. We did all kinds of really fun things. But then the One conference was so incredibly amazing, and we were so thankful that we went, because the stuff that we learned there then gave us the initiative and the passion and really the empowerment to go back to our units. Just to explain our units, we are a children's facility. We are in Omaha, Nebraska. Unfortunately, fortunately or unfortunately, there are also lots of other NICU units in the city. We, however, are the only level 4 in the city. So most of you know that means we have acute surgical children, post-op kids, pre-op hearts, neurosurgery kids, genetic kids, metabolic. So we have all of the multidisciplinary teams that interact with us. And then obviously we're run with nurses, NNPs. We just have a new fellowship program which just started. We're all very excited about NEOs, PT, OT, and all the other services that are involved with the level 4 NICU.
Level 4 in our region even.
Yes,
just to
true.
extrapolate that.
So we have the little plane because we wanted to just tell everybody, Heather and I have very definitive memory on the very last day of the one conference. You're not inundated, but you're just given all these wonderful, fantastic ideas, just like this year has been. Aromatherapy, music therapy, using all kinds of complementary stuff. You can talk skin to skin, all the wonderful dissertations that people have been working on. And Kathy got up on the very last day and she really talked about, you guys are the one. You have the opportunity. Just Mary's quote from Helen Keller, we can't do everything, but we can do one thing. And because we can do that one thing, we can go back. And then the other thing is we had 2 of us actually who could work together. So we sat after the conference was over and we were trying to remember if the flight home was late in the day, but we had time to kind of sit and talk about it. And right away, we were both like, it's skin to skin. We've got all the data. We have everything that we need to go back with. We knew that our unit was severely lacking. So we decided that was going to be it. And I just wanted to give a little back history on our unit. We had 42 beds. We had increased those numbers about 4 or 5 years ago with the remodel phase. But about 8 years ago, the unit we underwent what I affectionately call the divorce. We lost more than 3/4 of our NEOs to a different unit. And with that, not only the NEOs, but also some very experienced nurses. Because when I started here 14 years ago, skin to skin was very much a part of the care. The nurses felt very empowered to take babies who are on oscillators out and do skin to skin. And really, they didn't ask. It was just part of the culture at that point. But when the divorce happened, brand new nurses came. We had a few changes in our neonatology staff that you'll see caused a complete backwards slide of what the skin to skin culture and how it happened. That was a little bit of an explanation of, because we're going to have to show you what our numbers were pre-intervention, and we just wanted to give a little bit of an explanation.
So this is our data of Kangaroo holds the 6 months prior to when we started our intervention. So at this point in time, we were ranging between 7 to 28 holds per month with a median of 11. And I would just say these were just Kangaroo care holds is what we were extracting from our medical record. This didn't include if the baby was held in a swaddle wrap or by other members of the family. So babies were being held, but we were focusing specifically on our Kangaroo holds. We also knew that our data was not accurate and that at the time the way that our nurses were documenting was very cumbersome, and we knew that our numbers were lower than probably what they really were on the unit, but we just didn't have a really good idea of where we were at. But this was our pre-data before we started our intervention. So Kim and I knew that we couldn't do this alone. We needed a team of people together, and we knew it was going to take a big team because we were looking at a culture shift in our unit at this time. We did have a developmental care committee that was already in place, so we were fortunate in that we had a group of people. I think that at the time, this group of people too, it just was a good mix of people and was the right people that we needed at the time to make this culture change that we were looking to do. It was a well-established group. We had been meeting for around 10 years. We meet every other month, and it's a multidisciplinary group of people. And part of my role is to help facilitate this group and then also help do the tasky type things that it takes to implement developmental care into the unit. And so our group had been really aware and wanting to work on our skin to skin holding in the unit. We had done some small things. We had purchased some skin wraps. We had worked with our marketing department and made some parent brochures on the benefit of skin to skin. We have a bi-weekly newsletter that we had put some information in it, but we just really hadn't seen that significant culture change that we were looking for. So we knew that we needed to make some significant changes. At the time, our medical director, and we had Kim involved, we had another nurse practitioner as well, and they were really instrumental in helping us be advocates, and they were loud voices for us to help make policy changes that we needed to make. We had bedside nurses, both day and night shift, who were willing to go out on the unit and start initiating and doing the holding and then being mentors to staff members. You'll meet Megan, one of our nurse educators, later in our talk, but just her energy and creativity and drive was super important. We had managers, and then our NICU director allowed us time and money, what you need to make a change, and that was very helpful. And then we had our ancillary team ancillary team members who were just at the bedside as well and helping to reinforce the education and the importance of skin to skin holding. So it was kind of a circle group of people that just really came together and surrounded our unit to be able to help make these changes. So one of the things we did early on as we started meeting was we put together a survey and we sent it out to our staff, to our bedside staff, so that we could better understand and really get a feel for what our barriers were on our unit. And so right away, we realized that our unit policy was just very conservative in terms of the babies that were allowed to be held. So we knew that we needed to make some revisions to that and revisit that, and where people could come to a more comfortable level to allow more babies to be held sooner and more frequently. We talked a lot about our staffing and our time constraints. We have a lot of babies on our unit that are intubated, and so to get our intubated babies out, we use an RT and a nurse, and brainstorming and talking about how to be efficient with staffing and communication between team members to make holding possible. Our NICU environment and our culture, we just realized, frankly, it just wasn't, unfortunately, a priority kind of in the day-to-day tasks at this point in time. I think just the acuity sometimes and the infant stability in our unit trumped skin to skin holding and promoting that. Many of our parents do not live, since we're a regional facility, they don't live close by. So sometimes it can be difficult for them to be present at the bedside, or many times they've already been hospitalized for a long period of time before they come to our unit, and they have other ways that they need to get back to. And then I think because sometimes we just weren't starting it sooner and more frequently, then parents had more anxiety to be with their babies and to hold their babies. Extubation was a big concern early on. It was a hot topic in our unit at the time, and we were working hard to decrease our unplanned extubations. And so I think there was a lot of nervousness around staff's perceptions that potentially doing more skin to skin holding could increase our risk for unplanned extubations. And then certainly we knew that we needed to re-educate and taking a deeper dive into education of both our staff and our families so that they really understood the incredible benefits of skin to skin holding. So after we looked at our data, we did a lot of literature-based review in our group. We looked at our barriers. The group kind of came up with these 4 interventions that we felt like really needed to occur simultaneously in order for us to have the change that we were looking for. We knew we needed to revise our policy, and we developed a subcommittee, a smaller committee, to really look at the policy, which was very much driven by Kim to do that. We knew that we needed to look at our documentation, how nursing was documenting, and make that easier and more efficient for them so that we knew that it was consistently being done and that we could have better data to support and follow what progress we were making. This was one of our bedside nurses' ideas, and it was one of my favorite, that we really wanted to discuss kangaroo care in our medical rounds. Families are invited and are part of our medical rounds, and what better way to discuss that and have the parents involved and everybody on the same page as to a baby's candidacy when they could start kangaroo care, and just to advocate for it and to talk about the benefits. And then we wanted to re-educate our staff and our families as well. So this was a bundled intervention that we put together. I would say it was like probably my favorite meeting of all time here at Children's, because it was like such an energized, engaged group of people, and everybody contributed and had such great ideas. And it was just very passion filled. We left there so excited, and we were like ready to take on the unit.
And just to echo Heather's comment when we were talking about this yesterday, you all know that when you come back from a conference and you're really excited about something, and then you come back and you tell about it, and everybody's, oh, that's not going to work. I mean, there's no way that's going to work. Why do you guys, oh, we're going to have so many unplanned extubations. But it really didn't happen that way. It's like Heather said, it's like we just came back at the level of excitement, and then our unit just caught on and just went with it, which was extremely beneficial to changing the unit, but it also helped us because we didn't get crushed when we got back. I'm going to talk about each of the interventions that we included in the bundle. Heather was very good when she said our policy was conservative. Those people who know me really well know I use very colorful words. And when she said Kim is a loud voice, I technically have a very loud voice sometimes. Everybody knows that. I know that. It's something I'm aware of, but conservative would not be a term I used for all the exclusion criteria on our kangaroo care policy. When we got back and we looked at it, on the left you can see, and I did this yesterday, kept putting my hand in front of the camera, so I'll try not to do that. But on the left of the slide, you can see all the things that we were not allowed to hold a baby for, and it's nearly everything. So especially when you work in a level 4, intubated on active ventilator weaning, high frequency, apnea or bradycardia spells that have increasing interventions, phototherapy that's on 3 banks, less than 24 hours postoperative status. It's like almost everything. So you can understand why we had a culture that the nurses just felt squashed, and perhaps understand why when we offered a new policy and a new bundle, while the nurses were like, yes, that they could actually do something at the bedside that was helpful. So the stuff on the left side was our pre-intervention exclusion. Everything on the left is pre-intervention, and then everything on the right is after we had the bundled interventions. And I'll tell you right now, we hold with therapeutic hypothermia, and we do hold babies who are less than 72 hours because you can work around that and still keep the baby in midline. No, it's not technically chest to chest and all that. So the only really exclusion that we have right now is parents with a rash or open skin lesions. I'll allude to something else later, but we do, I was going to talk about it now. One of the talks with the poster presentation that Lauren helped talk about with CHOP was they're really working hard to increase the holding on their surgical patients. And I will readily admit that as a group and something that I'm taking away, that we need to be better about holding. Now that involves a whole nother discipline that we're going to have to work with. But the good news is we have a new surgical team, so it might be the perfect point to introduce the vision tree that Lauren and CHOP have. So it's just an ongoing process that we talk about what's excluded and what isn't. The next one was a no-brainer for Heather and I too, because as we were on the plane and we were talking about the things that we could do, we knew, and she said it earlier, we weren't sure that nurses weren't actually holding the babies or having them held in skin to skin more, because multiple times they would complain about Epic and it has flow sheets, and it was in an unusual spot. You had to document it in 2 places that had nothing to do with each other. Really didn't make sense where the skin to skin was or the kangaroo hold. And then as also part of this squashing of wanting to hold babies or letting parents hold, we were expecting the nurses to do every 15-minute vital signs, and that included a temperature, people. So you know that bedside nurses are like, yeah, no, I don't have time for that. That's what I have to do for blood. So we again jumped through all the hoops with the Epic team to make sure that we put the skin to skin hold in an area that made perfect sense to the nurses. We stopped the every 15-minute vital signs because we have central monitoring. So the bedside nurse can be either in the room with them, where most of them feel comfortable doing, especially with our super sick babies, or right outside the room watching the central monitoring. And then all they have to do is document how many minutes the baby was actually held. So if you want to get the nurses on board, you make the documentation much easier. Heather already alluded to this piece of the intervention bundle too, and how important it was to both of us. And I think it's super cool that it was actually a bedside nurse that came up with this idea. Because we're on Epic, we have notes that are copied forward and then changed each day by the NP staff. But on the very bottom, there's a section that deals with day-to-day cares, or does the baby need immunizations? But in that area, we just included, can the baby do skin to skin? One, it's an everyday visual reminder. And two, because it's in the rounding process, both the nurse and the parents can talk about it in rounds. And what I have found from being in rounds, it's very often a conversation that the nurse and the parents will have before they come back to rounds. And they'll say, hey, so yesterday you guys were a little bit unsure, said maybe he was too unstable. Can today we hold the baby? Or I'll say to the family, have you held the baby today? Has the bedside nurse got the baby out? Because that's the other thing Heather and I haven't talked about. We knew that in order to get this initiative also started, yes, it did go well, but we knew that the people who really needed to buy into it were the parents, because they're the ones who are going to be at the bedside. They need to know the benefits of it. And then they can say to their nurse, hey, today I'm going to be here at 1 o'clock. I'd really like to hold the baby for a couple hours when I come. The nurse can then get it into her plan of care. We know that the respiratory therapist is available then, and that's what we've really found happens. The nurse, if the parent is there and available, will set it out in their plan of care. So it really did it improved the communication between not just the staff and the care team, the NMPs and the physicians, but also the staff and the family, because it's something that they can talk about on a daily basis. So this was one of the cooler ones that we were super proud of. Obviously, when you present a culture change or anything that's not necessarily new, but that you really want to be changed, it's about staff education. So we came armed with loads of information from the one conference, and we're ready. And even the evidence-based stuff that we looked up in the developmental care team, this is all Heather. I have to tell you guys this. She did so much of this. She worked on and even the next slide will be the parental education. And I'm serious when I say this. She did the PowerPoint. Megan did do our newsletter. You'll again see the picture of her later. She's very bouncy, and you just cannot say no to Heather and Megan both. But we knew that the education had to come. The other thing that was really super interesting to Heather and I was then out of the staff education, we had already prepared our developmental care team members to serve as quote unquote champions. We have both day nurses and night nurses. And then as nurse practitioners, we work days and nights. Liz and I were there both days and nights. But we wanted those people to at least be our champions. What we didn't know would happen, and what was super exciting, is we had bedside nurses who became what we termed unexpected champions, who they were the brave ones who started doing it on the babies who were really sick, who had lots of lines. And then they were like, nope, we're going to do this. We're going to get your baby out. Everything's going to be okay. So once the staff education came through, once the developmental care team members were out on the floor, and then once we had all of those extra people, then people got brave, people started doing it. And so education and then doing.
So our timeline, as we were working through all these phases, lined up perfectly. Actually, May came around, which is Kangaroo Care Month. And so we got overexcited about this big celebration that we could have, and that we could really capitalize on Kangaroo Care Month. And we were fortunate. We did get financial support from the unit, and we were able to buy t-shirts. We used the slogan on the back, Kangaroo Care Wrapped in Love, which was symbolic of what we were trying to do, and we felt like it wrapped all the benefits of skin-to-skin holding into this slogan. The champions all wore the shirt during our week of education, and they became very sought after. They were uniform approved, so nurses could wear them to work and on their shifts. So we then expanded this out over the next 6 months. Sustainability, to try to continue to keep it at the forefront of everybody's minds. And we had a little competition where each time the bedside nurse documented that they did skin to skin with their baby, bedside, day shift, and night shift nurse, then they went into a drawing to win a free t-shirt. So that's always great. Everybody loves a free t-shirt. But it really helped just incentivize and continue the project moving forward. We also bought a kangaroo costume, and Megan, our staff member, hopped around the unit. Our nurse manager makes these little cookies that I just put a picture up here of because they're amazing. And then we attached education cards to the cookies for families just to review the benefits of skin-to-skin holding. And then the families were also entered into drawings to win prizes. So one of our unexpected champions, one of our nurses, I remember I came in on a Monday morning, and a couple nurses approached me right away as I came on the unit, and they were so excited to share with me a very sick baby that they had gotten out over the weekend to hold, a baby that before would have never been even thought of to hold. And she had advocated, and they had gotten this baby out. And I just remember her telling me it was the longest hour and a half of any shift I've ever worked, because she was nervous the whole time the baby was out of the isolette. And was the baby going to be extubated, or was something going to happen? And nothing happened. It was a great experience, but it really was a testament, though, to, I think at that time, the bravery and the vulnerability and the courage that the nursing staff went through this transformation to help make this culture change. So this is just our kangaroo. This is Dr. Birch, our medical director and one of our neonatologists. And every year we add to what we're doing out on the unit during Kangaroo Care Month. And now we have these little signs that we put up as well. But it really has served to help continue the celebration every year, keep it at the forefronts of our minds. And I think it has helped to improve our sustainability of the project over the years. And we certainly continue to always improve our numbers. That's always the goal.
Yeah.
More opportunities for more holding.
Yeah. So the next slide is just another visual of the pre and the post data. I can remember when Heather told me once we got the data for July, and I think I was in her office and I was like, "You're kidding. What? How many holds did we have in the first month?" It was so incredibly exciting after all the work that the developmental care team had done, how passionate we were about it, to actually see a number that we were so pathetic to begin with. We thought we would see a modest improvement, but to have to go from an average monthly hold of 11 to 87 is what that number is at the end. So super excited. I remember also Heather presented the data at the developmental care team meeting. And again, lots of excitement from the team and just continued excitement. And we're going to keep this up and we're going to continue to do it and just everything. And then she came to NeuroNICU rounds and presented the data there. And I also will never forget that day, because Dr. Peeples came over to us and congratulated us and was like, "That's great data. Now are you guys going to write this up?" And I was like, and I go, "We weren't planning to," something like that. And he said, "I'm going to stand here until I get the answer that I want from you." And I was like, okay. I was telling Heather too, I remember telling Kathy, because we'd had this data when I saw Kathy, because I think it was October 2018 that I saw her, and she said the exact same thing. "You guys are going to write this up?" And I was like, "Yeah." We did end up writing it up. It was a process that Heather and I some days it was really good and some days it was really hard. There are a lot of things that you need to include in an article. The next two charts you're going to see are just some of the data that we collected over the next year. And then these charts are actually included in the article that was published in Neonatal Network, and it was in March, April, I think, of this year that it finally came out. Interesting fact, my unit manager also was published in the same magazine, and so that was cool. But you can see when Heather and I were talking about this yesterday, we were like, what was the green line? And it was to have one hold per average daily census. So we run usually about 30. So that's what the numbers you're seeing. The goal was about 30 holds a month, which is extremely modest for us to ask for that. We could have set the goal higher, but I think we were afraid to after the pathetic start or time that we had before. When we were writing the article and then turning it in, they wanted us to address what happened with the drop down, which was still at goal, but definitely below the other high numbers that we had. And when we discussed it, we remembered that the acuity and our numbers in the unit were extremely high, and just probably what we think would happen was all of those barriers that we talked about before, time restraints, staffing, stuff like that just inched its way back in, and people just weren't making it a priority, because when you get large numbers, nurses have to take more patients. It's just not doable to, sometimes when it's that busy, to do skin to skin. Although we did manage to keep it at goal or just slightly below. The next one talks about, of course, when you're talking about increasing skin to skin, unplanned extubations is the big topic, because that was the thing that people were most upset about. You know, we're trying to stop having all these unplanned extubations, and now you want us, not lots of people, but there were a few, and now you want us to get him out. Do you really think that's advisable? So Eric, again, he's the smart one. We said if you had questions and we didn't really understand how to answer because of these lovely charts that he's made, we would refer you on to him because he's the brains in this little unit of ours. But what the goal showed you is that, honestly, when we looked at the numbers, our unplanned extubations did not go up when we started increasing our numbers for skin to skin. You can see, like much of the other units, sometimes we have a really good month and sometimes we have a really bad month, but the numbers did not overall change just because we increased the amount of skin to skin. I will tell you, we are still fighting the battle for unplanned extubations in the unit and working really hard, just like I know every other unit in the United States is. But just so you know, our safety of our babies was not compromised just for increasing skin to skin. Of course, what do you hope for when you come back and you're super passionate about a new intervention? You want a culture change. And we can honestly say, without a shadow of a doubt, our culture has completely and totally changed. Our numbers remain high for skin to skin. The nurses really want things that they can do autonomously, and this is one. They don't have to talk to me unless they're questioning, you know, Kim, this is a fresh post-op, what do you think? But at least they have the tools, they have the knowledge, and they're empowered now to come and ask us, because the culture is that the babies will be held, not if the baby gets held, you're going to get in trouble like it used to be. So it's really about nurse autonomy. It's about teamwork between the respiratory therapists. And a lot of the nurses will talk to Heather about, if they can't hold them skin to skin, what are the things that the parents can do at the bedside to be more involved in the care? And then this is a standard practice of care now. These babies are expected to be held. So that's just what one of the things we were talking about when we were making the talk is, it was actually around May that we were talking about it and putting the slides together. And so we were doing kangaroo care, which you can tell that picture was from this year because we all have masks on. One of the nurses actually said, so this will tell you what the culture is now. Do we even need to celebrate Kangaroo Care Month? Because we just do it now. And I was like, yes, because that's exactly what you want. You want it to be normal, that it's just what happens when you're here. And then again, that the parents are asking and advocating to hold their babies. That's what they want to do. It just makes my heart super happy when I say, have you held the baby? Oh yeah, I asked. We started doing that several days ago. And the things that we have learned from this project now are actually helping us implement our next big change, because Heather and the team noticed that our swaddled tub bathing has fallen out and just is almost non-existent now. And people are doing a lot of spit baths, that's what I call them, not actually putting the babies in. And so the steps that we went through to make this culture change, we're now re-implementing again. So all the QI stuff that you do, we're implementing it again to help increase our swaddled tub bathing. I like Mary's little quote a little bit better than ours, but we like the comment from Mahatma Gandhi, be the change that you wish to see in your world. And our world is obviously, when we're at work, the NICU. So this conference has done a spectacular job of, like I said before, presenting multiple things that you can go back to. I have a list of things that I have picked up from, and Heather and I were discussing some of them yesterday. What can we do to make the unit a better place for our parents, for our nurses, and for us? So this whole talk was for you guys in the audience to know that you can be the one, because we were the ones, and to be the ones that are in the audience wanting to make a change. Know that you can do it. Find a buddy who thinks like you. Find a buddy who can be your friend and your encourager. And that's it. We just really wanted to give our story so that hopefully you guys can leave the conference and know that it is doable. That is all. There you go. Stop sharing, maybe.
Thank you so much to both of you, Kim and Heather. Just to go through, we're taking questions. So if anybody has questions, please post them in the chat and I will make sure that Kim and Heather hear them. People are commenting, well done. They love your quote just as much as anyone else's. Crystal is asking, do you teach skin to skin with umbilical lines, so UVs, UAs? And I know that's a question that probably many of us have entertained in our units on a regular basis.
This still remains a hot topic with people, and the nurses will very often ask, especially we have even held with low-lying UVCs. It gives me heart palpitations to do it, but we do. And when we do that, not only do we have another RT, but we have at least two nurses at the bedside. So one is not just watching the baby and the other is completely in control of the lines, but we totally do it with umbilical lines.
I know at Children's in Philly, we also do hold with umbilical lines, but it always creates question and unease from people, and they always want someone else to verify that it really is okay to do this. Yeah. Jackie is asking, did you have respiratory involved in your team that you formed? Was there a respiratory representative on that?
So initially we did not have a respiratory therapist on the team, but we did for sure engage them as we were rolling, which we didn't do a very good job of talking about, because obviously when you're going to start asking someone to spend a little bit more time at the bedside, we definitely did start talking to their team and saying, hey, this is the expectation now. If we get the baby out, you guys need to be there. This is how the hold's going to happen. We need you to do this. You're responsible for the tube. So we did for sure engage the respiratory therapy team, even though we don't have them on the developmental care team.
Okay. Another question, can you please share your unit survey so we can take inspiration and not reinvent the wheel?
Do you still have it?
Yeah, I can go back and find that.
What's so funny is it's been so long since it's not long, it was 3 years ago. And when we were rehearsing this yesterday, Heather goes, Kim, do you remember we did a survey? I was like, no, we didn't. Did we? I don't even remember doing a survey. She's like, yeah, we totally did a survey to ask about barriers. So yeah, we can totally do that.
Yeah, and so if you're willing, you can, if you even just share it with Kathy and then they can post it on the conference site.
I did it through SurveyMonkey, so I'll go back and see if I can pull it back through from that time frame.
Yeah.
Okay.
Sure.
Great. Yeah. Are there any best practices that you can share for holding when on the oscillator? Any special chairs, tables, etc., that you guys have used to help in your unit?
It's so interesting because I heard, I think it was Jane and somebody else talking about this, that they had tried a different chair and nobody liked the chair, so they didn't use the chair anymore. We really haven't.
No, we've just used the equipment we have. Yeah. Say creativity and lots of hands.
Yes.
And propping, and
yeah,
we have little hooks, I don't know what those are called, that are Velcro that we use a lot to secure the lines to clothing.
Yeah,
I think, which helps.
Yeah.
Do you just have standard like recliner chairs or rocking chairs?
Yep, just the standard recliner. Yeah. That was the other thing that I think the nurses had to really get adjusted to is we don't do the flying method where you just, because they were also talking about that. The moms at the bedside. Heather did do a lot of teaching with the bedside nurses about getting next to the bed, putting the baby with them, and then sitting down, because that definitely we have to teach a different procedure or protocol with how you take the babies out.
Let's see. Your unit rocks. Great job. You both are an inspiration. People are also asking for a link for your paper, or even if we find I guess maybe the citation, we could always throw that in there.
Okay, yeah, because it was the March, April Neonatal Network. Yeah.
I can try to look after we're done too and post it in there. Do you use a wrap?
Yeah, so the wrap is...
We use a wrap called the NeuroNICU wrap. So it's a shirt that they put on, and then it has Velcro that crosses over and supports the baby. And I think sometimes you walk in and the mom just has the baby on the chest and blankets over her. This is actually, she pulls it up and over, and then it's a shirt so that the baby's just tucked right in there with him. It's a fantastic product.
So do you guys give that to each mom?
Yes.
On the unit?
We have shirts that we launder and then we reuse them.
Okay.
Yeah. And certainly some moms on our unit just don't want to mess with that. They just will use their own clothing or will just use a blanket. So it's just really parent preference on what's most comfortable for them.
We had a dad one time who had twin boys, and he bought dad skin to skin shirts. And then he was modeling them for people and giving all the links out to all these dads. He was probably one of our biggest advocates for skin to skin for dads. I was like, we need to tape you so that we can show all the dads how, twin boys. And he was like, oh yeah, I bought a special shirt on Amazon for skin to skin, and it's the best thing ever. And
That's awesome. From Diane, great work. Are you routinely holding your cooled babies? And I know you said you're not doing skin to skin for your cooled babies, but are you guys routinely holding?
Yeah, so we do what Kathy has started talking about, I feel like maybe a year and a half or 2 years ago, just taking them out on the pillow and putting a cooling blanket right on there. That took some convincing too, because you're talking about the blanket lines, sometimes an intubated baby, and not, I would say, probably as routinely as I'd like to, but definitely telling the bedside nurses this is an option. When the mom gets out of the hospital and the dad, we can take the baby out. So yeah, we do.
Awesome. And I don't know if I've read this one. Your progress with improving the frequency of kangaroo care at your institution and your outcomes are amazing. Thanks for being an inspiration to us all. Any other questions? You guys did great, and your charts show that it was amazing work.
Thank you, guys.
Thank you. Thank you.
Thanks again for the opportunity too.
Here's one last question. What do you use to maintain midline during holding?
Are they talking about the really small babies, I'm assuming, right?
Less than 32 weeks. I would say this is a newer thing we have started doing, and just maybe not true skin to skin, but just holding the baby's head in midline or
sideways.
Yes, on their side and up against the stomach, more of a sideline position.
Yeah,
is what we've tried a few times. We're still kind of in the progress with that. I think it's been more recent.
Yeah, you can give us more updates next.
Yeah.
Thank you so much, ladies. That's great work.
Thank you.
Thank you.
Thanks again for being here as part of our live stream. I hope you enjoyed the presentation and the Q&A time with Kim and Heather. And thank you again to Lauren Heimel, who was part of our planning committee, who was actually doing all of the introductions. I hope you've enjoyed this presentation with Heather and Kim as they discuss the change that they made, the real life change that they made in their unit. If you want to get the resources related to this presentation, click the link in the show notes, as well as maybe use the QR code that's probably somewhere on this screen. So anyways, I hope that I'll see you again in another live stream. Don't forget to subscribe to our channel and to like this so that YouTube knows to send you more of our videos, and hit the notification button and you'll be notified when we do our next live stream.